Hello, everyone. Welcome back to the APP Didactics. And this month is Women's History Month. And so I wanted to take advantage of that and talk a little bit about how far we've come in the surgical breast cancer history. So I titled it From Radical to Refined: How Breast Cancer Surgery Evolved. And obviously, as a surgeon, I want to just focus on the surgeries. And I am actually doing a very similar thing for my podcast this month, but very layman, simplified version. And you guys get the professional version. So these are different slides than what I used for the podcast. So these are most of these women have made a significant impact for breast cancer world. And so you can Google and find out about each one of them. They are amazing. All right. So happy Women's History Month. As we kick off Women's History Month, looking at how breast cancer, the retrospective aspect of the breast cancer and how women fought for autonomy and changed the landscape of clinical research and transformed a hush diagnosis into a global movement. It is a heavy topic, but it highlights how far we've come, not just in science, but our willingness to speak openly about women's health. Breast cancer surgery used to be extremely disfiguring and disabling. Over time, studies proved smaller operations could work just as well for survival. And the evolution is about science, patients' voices, and also rethinking radical. So we'll start with the Egyptian era. So ancient, in the 3000 BC, Dr. I don't know if he was a doctor, but Papyrus, ancient Egypt, he described breast tumors as cold to touch. And basically, he said there was no treatment for it. They're incurable. And for many years, this was a reality for women. They did not get treated for breast cancer. Again, Hippocrates is the first person to name or use the word cancer. In Greek, it's called carcinos or carcinoma because it looked like a crab. And in surgery, when you're able to feel a tumor in surgery, it does look like it has those crab legs. And in the 2nd century, Galen believed that cancer was excess of black bile, and surgery was often avoided as it was thought to provoke the disease. And we know scientifically how incorrect that is. And then there is a reality in 1846, women were having surgery without anesthesia. This was before the invention of anesthesia. Surgeries were brutal. They're like chopping off women's breasts while women were awake. And women, did not die of cancer. They died of surgery because it was just so brutal and devastating. And patients died from bleeding and, infection and shock. And again, so Dr. Halsted, so this is called the era of mutilation between 1882 to 1970. So this happened almost 100 years. And before this time, like I said, they were removing the breast tumors without anesthesia, but cancer off, if people were alive and did not die from surgery and infection, the cancers came back because they did nothing else other than just removing the lump. So then Halsted came up with this approach and this thinking where the centrifugal thinking, meaning cancer spread outward. So it started in the breast and it went outward. So his thinking was that you have to take out everything where the cancer is. So the breast, the pectoralis major, minor, the lymph nodes, level 1, level 2, level 3, the serratus. There's all these muscles were removed and it left them very disfigured. Women had terrible lymphedema, physical disability, hollow chests, but this was considered gold standard back in the day, and that was a standard of surgery for 90 years. And thank God I wasn't born in that time. Then there's a huge paradigm shift that happened in the 70s, early 70s. Dr. Fisher, who is a pioneer of this NSABP 04, National Surgical Adjuvant Breast and Bowel Project, 04 trial, where Fisher argued that cancer is a systemic disease. It travels through the blood, meaning massive local surgery would not improve survival. So he actually is responsible for this rise of modified radical mastectomy, him and a couple of other guys. And they removed not just breast tissue and level 1 and level 2 lymph nodes, but left the pectoralis muscles intact, which, it was less morbid. And back in the day also, when women went to surgery, they had biopsy under anesthesia, and also they woke up without breasts. It's called the one-step procedure. So that imagine going to sleep not knowing whether you're going to wake up with or without breast. So this journalist, Rose Kushner, she fought against it. She fought against this one step. And I think of there are so many women that were pioneers in this space, but I think that this lady really made a huge change she demanded a biopsy before the mastectomy. And I mean, as we know, biopsy doesn't spread cancer and all that kind of stuff. So biopsy, then women had mastectomy after they gave informed consent. So we women had choice on what they wanted, and so we really credit Rose Kushner for that. There were a number of women who made extensive contributions to breast cancer world. I'll just mention a couple. Dr. Jane Cookwright, known as godmother of chemotherapy, she treated all. This is the time when cancer was treated with the surgery only, but she developed use of methotrexate to treat breast tumors. So obviously, we don't use that for breast cancer anymore. But she was the only woman of the 7 founders of American Society of Clinical Oncology. Then there is Mary Claire King in the 1990s. She said breast cancer could be inherited. So about 10% of the time it can be inherited. So she also identified BRCA1 gene on chromosome 7. Her work turned breast cancer from mystery into something we could predict and prevent through genetic testing. Then Betty Ford, the first lady, former first lady, in 1974, just weeks after becoming the first lady, she went public with her mastectomy. So it was very hard to overstate how shocking this was in 74. Her openness led to massive spike in screenings across the US. And I really think when we share our story, and those of us who have done this and openly, it really gives permission for other women to come out. Then it doesn't become a disease this remains in secrecy. Last night I gave a talk at the South Asian Women's like this fashion show, and in a lot of the communities, people don't talk about their family history. Even my own mother was appalled that I was going on TV and talking about my history, my diagnosis of cancer. But it is so important if you feel comfortable to share our story, because there's a ripple effect that happens from sharing your story. It gives permission for other women to come out, and you just normalize it to feel the feelings as you get this diagnosis and go through all those emotions. So we'll talk about NSABP04. Again, this is where the radical mastectomy, what Halstead was performing, Fisher challenged it to be a total mastectomy, or modified radical mastectomy. Also, this is where we were not doing a lymph node dissection. And there was no survival benefit between the true trial arms, between the radical mastectomy and the total mastectomy. And then we went on to say that the routine axial lymph node dissection was not needed in node negative disease. In NSABP04, the modified radical mastectomy, which is removing the breast tissue, the level 1 and level 2 lymph nodes, versus lumpectomy, breast conservation, also did not show any differences. Now remember, randomized control studies or these gold standard studies, thousands of women are enrolling themselves in these studies. We have 20-year follow-up data with showing no overall survival benefit when you undergo this big extreme surgery versus the smaller surgery of lumpectomy and radiation. And so when we talk to patients, we tell them there are all these randomized control studies that have been performed, and women literally sacrifice themselves to undergo bigger surgery when perhaps they did not need to undergo that surgery, only so the rest of us who came after them can benefit from their sacrifice. So in the 80s to 2000s, lumpectomy was more being performed. We also started talking about lymph nodes. In 1990s, instead of performing a axial lymph node dissection, removing 10 to 11, 20 lymph nodes, which increases the risk of lymphedema, now we are performing a sentinel lymph node biopsy. That did not actually happen until 1990. So sentinel lymph node biopsy, that is where the lymph nodes that are first draining lymph nodes underneath the arm, those are the gatekeepers. And I'll talk about, I know you guys know already, but we use the dual tracer and we remove those first blue and hot nodes. Typically, we remove 1 to 3 as opposed to 10 to 20 that was performed with a lymph node dissection. Some of the other developments, oncoplastic surgery, this is where we combine the removal of the cancer with the plastic surgery techniques, either with combination of a plastic surgeon, or we as breast surgeons have learned some of the techniques to do this in order to maintain the shape of the breast for the woman, whether it's performing reduction or performing a mastectomy with reconstruction. There are different types of mastectomies. There's nipple sparing, where we preserve the skin and the nipple while removing the breast tissue. Skin sparing mastectomy, remove the breast tissue and the nipple, but keep the skin envelope for reconstruction. There's Goldilocks, where we remove the breast tissue. Sometimes we leave the nipple, sometimes we don't. Really depends on the location of the cancer. And we create the skin envelope to create a breast mound. These women, this can act as a bridge if they later want to have reconstruction, or they can just remain with a Goldilocks mastectomy. They would just look like they had breast reduction with a smaller breast. And I would say this has been the most fulfilling surgery for me at Ohio Health in the last 11 years. In the first 6, 7 years of my practice here, I really struggled not having plastic surgery services for the underserved patients. And of course, as you all know, besides education, helping the underserved is my thing. And so, I had to come up with different method to help these underserved women, and this has been a great addition. And really, we always say, you want large tonic breasts, but this technique can pretty much work in any breast size women, and they can always have an option down the road to get reconstruction down the road. If they start with a smaller C or less, they really don't have any mound. They kind of go flat, but at least you can preserve the nipple. But you really want those really large tonic women, which we have a lot of obesity and diabetes and smoking and all that stuff in Ohio. We do have a lot of women who have really large tonic breasts. Then, as you know, total mastectomy with flat closure. As breast surgeons, we really need to be able to perform this. And this is where we remove the breast tissue, remove those dog ears, remove those excess tissue. And sometimes it's difficult to accomplish it all in one surgery because patients are laying on their back and their arms on the side. Sometimes the tissue, not the breast tissue, but their skin and the fat goes beyond to the back, and sometimes you have to bring them back for a second surgery. That's really happened. I want to say less than 5% for me, but I feel very grateful to Dr. Cripe for teaching me this procedure in my fellowship, that I was able to incorporate it for my patients. So let's talk about some guidelines for margins. And of course, this talk is for you guys, more professional talk. I didn't talk about any of these things or at least the margin status for my podcast viewers or listeners. Okay, let's talk about margins. There is this SSO Astro guidelines that came up in 2013, right when I was graduating. Is they talked about margins. Back when I was a fellow, the margin status was everyone needed 2 millimeters or longer or higher length of margin for invasive breast cancer. But there was this meta-analysis that looked at 33 studies for many decades of years, and basically no ink on tumor for invasive cancer was just as good as getting wider margins. And wider margins did not lower the risk of ipsilateral breast tumor recurrence. And a lot of these acronyms, and I have at the end of the presentation, I have the definitions of each one of them if you don't understand it as you're looking through the PowerPoint. And so you don't need to remove a huge area of the breast tissue when you're performing a lumpectomy, but you do want to remove enough to remove the tumor, just barely enough around it, because why? The radiation takes care of any microscopic disease. They're also going to get endocrine therapy if they're hormone receptor positive, which is the majority of the cancer. Now, there's also this study, the shave margin study that happened early 2011. Basically, the re-excision rates be decreased? Meaning, if a woman has a lumpectomy, the rates of positive margins were anywhere from 20 to 70% across the country and across the physicians. So there is Agnes Chagpar is a breast surgeon who looked at this at their institution, and their study, she said that shave margins versus no shave margins, meaning when you remove additional tissue, you're doing a lumpectomy and you're removing all 6 margins or selective shave margins, your re-excision rate is less than the re-excision rate if you did not do any shave margins. She also argues the point that cosmetically the breast doesn't look any different, a decreased risk of infection because you're not going second time for surgery. I feel like anytime you go back a second time for additional surgery, there's increased risk of infection. So I am probably maybe the only surgeon, maybe other surgeons do this, I don't know, but I do all 6 shave margins. And the reason for that is this. Number one, my lumpectomies are super small. Number two, the additional margins I'm taking is extremely thin amount of tissue. And for me, my re-excision rate is somewhere around 5-6%, which is very good number. You don't want your re-excision rate to be 0%. That is just now telling me that if your re-excision rate is 0%, you're really taking big chunk of tissue, and that creates seromas and cosmetic problems for the patients. So this study really has been great, and I do use it. Mel Silverstein is this guy who's in his 80s. He like started his work when radical mastectomies were performed. Now he performs radical lumpectomies, oncoplastic reduction lumpectomies, and he really strongly believes in routine shave margins, and that's kind of who I got the idea from, and do it in my own practice. Let's talk about DCIS, non-invasive cancer. There is this NSABP B17. The question I'd asked is, can DCIS be treated with breast conservation? And of course, if it's a small amount of DCIS, you can treat it with lumpectomy. And most of the time, these women get radiation. There's a lot of nuances to this, but radiation does decrease local reoccurrence. It does not change survival, mind you. It decreases local reoccurrences. When we talk about invasive cancer, we talk about radiation decreasing survival, but not, I'm sorry, radiation improving survival. But for the DCIS, it doesn't change survival, it just reduces reoccurrence. And then what are the margins for DCIS? I hate DCIS because DCIS, if it's going in a duct, sometimes it can skip. There could be skipped areas of DCIS. So if you've got negative margins, that doesn't mean there's more DCIS down the road. So the question is, or the from that, what came about that from that is you need 2 millimeter margins for DCIS, no incon tumor for the invasive cancer. And so that comes from, again, this SSO guidelines looking for DCIS. I talked about this earlier, the classical lymph node dissection where we remove 10 to 20 lymph nodes versus a sentinel lymph node biopsy. In the 1990s is the first time this was performed. Up until the 90s, all women got lymph node dissection. So sentinel lymph node is based on this premise. When you inject the blue dye in the radioactive tracer, it goes into these gatekeepers, the first sentinel, meaning the first person that shows up in the military. So sentinel lymph nodes. So you remove 1 to 3 lymph nodes while sparing a lymph node dissection, no survival difference. Z11, we talk about this a lot. This is for those women who have a small disease, so less than 5 centimeter disease, T1 or T2. They're clinically lymph node negative, meaning they could have a diagnosed positive lymph node, but palpability, when you're palpating the lymph node, you don't feel it. That's clinically negative lymph node. But in Ohio, we pretty much can't palpate anyone's lymph nodes because we're all big here. We like to eat. So sometimes we use this to our advantage to decrease the risk of lymphedema by not performing a lymph node dissection. So basically, if a person has 1 or 2 positive lymph nodes, they're getting a lumpectomy or a mastectomy, because we have the same data to show in mastectomy by the Amorose study. Z11 only looked at lumpectomies. Amorose looked at women who had mastectomies. You could omit a lymph node dissection and just perform lymph node biopsy. No change in disease-free survival or overall survival. If they have 3 lymph nodes or more, then they need lymph node dissection. Now remember, these patients did not get neoadjuvant therapies. The Amorose patients didn't. This Z11 patients did not. So let's talk about those patients who had neoadjuvant chemotherapy. Meaning they had cancer, they're diagnosed with cancer, now they got chemotherapy, but they have a positive lymph node. Do they always need a lymph node dissection? Well, no, not really. And so that is the ACOSOC 1071. And this actually is very revolutionary study. It led to surgical de-escalation. Every patient that had a positive lymph node before neoadjuvant chemotherapy got lymph node dissection. But this study showed that if you use the dual tracer, the blue dye and the radioactive isotope, remove at least 3 lymph nodes, your false negative rate drops to less than 10%, meaning you get good sampling. So thousands of women now are spared of this radical node removal and preserving their range of motion, preserving their chronic lymphedema. This also shifted into this focused targeted axillary dissection, where now we remove that clipped node, and then we clip the lymph node before chemo, remove that lymph node after the chemo at the time of surgery. Again, that decreases the lymphedema rates without changing their survival. What we found is the neoadjuvant chemotherapy, in 40% of the time, it completely kills the cancer in the lymph nodes. So this is the great, thing about breast cancer patients. As a surgeon, I'm doing very little for them by removing this. Medical oncologists are real heroes here. They're giving the chemotherapy, whether in the neoadjuvant setting or the adjuvant setting, really helping the biology of the disease. And I'm removing it to prove that the cancer is there or cancer is gone. We talk choosing wisely a lot at the tumor board conferences. Don't routinely do a sentinel node in women over age 70. It's interesting. This is only for those women who are small tumor, hormone receptor positive. If they have a triple negative tumor, this doesn't apply. If they have HER2 positive tumor, this doesn't apply. Or if they have a large tumor, it doesn't apply. Sometimes we do kind of use it for up to 3 centimeters of tumor if they're like grade 1 tumors. And the caveat is these ladies really need to be on anti-estrogen medication. And the problem is sometimes they don't commit to it, don't take it. So now we kind of recommend radiation, even in this, short course radiation, or, whatever the course that they would require based on their cancer is what we recommend these days. And so now, choosing wisely is now extended to women under 70. So that's called the SOUND trial. You may have also heard in SEMA, that's another trial looking at omitting a lymph node dissect or sentinel lymph node biopsy in women under age 70. Again, same criteria applies. 2 centimeter disease, hormone receptor positive, does not apply to triple negatives or HER2 positive patients. And no change in survival, but they do need to get adjuvant therapies, whether it's radiation and endocrine therapy or radiation, chemo, and endocrine therapy. So what did we learn with these studies and all these trials? Well, back in the 1800s and before that, the thinking was simple: the cancer spreads outwards. But now, and the thought process was the more tissue you remove, the better chance for cure. Then that remained a standard, a gold standard for so many years. And these women woke up without breasts, without chest muscles, significant arm swelling, permanent disability. They were told this was necessary for survival. They didn't care about their appearance. They did not care about their mental health. They did not care about body image. What's important to understand is there's no randomized trials. Since those in the 1800s, there were thousands and thousands of women who sacrifice themselves so women like myself can have a lesser surgery. Or, I mean, I had a bilateral mastectomy, but that was my preference. I could have had a lumpectomy. So I had the option, and I did not get chemotherapy because of my genomic assay, oncotype. Some people, I mean, back before 10 years prior to my diagnosis, everyone over centimeter cancer got chemotherapy. So there is so many advances, and it's important for us to push for research trials because this does change the future for people. And back in the day, women did not question doctors. Now we question doctors, and rightfully so. And a lot happened since the 70s and 80s, not just in the surgical world for the mastectomy, lumpectomy, but also reconstruction. Women started having reconstruction. And we started asking, removing less could achieve the same survival. And in 1998, there is Women's Health Right Act, where it mandates women to get reconstruction, have a mastectomy on the contralateral side, have reduction lumpectomies, have symmetry procedures. Insurance is, the law mandates insurance to pay for that. And also, less surgery, lumpectomy, radiation, survival is the same as a radical mastectomy. Yes, survival is the same. It wasn't the bigger surgery that saved lives, it's the understanding that the biology of the disease. So for many patients, breast conservation is totally fine. It is important that we look at genomic tests, whether it's oncotype, which is what we use at Ohio Health, but a mammoprint is used in other places. It's important to talk about systemic therapy to safely de-escalate other things in other surgeries and other things. And so the goal is to, cause least harm, but also provide the same survival and shared decision making. What are some things we're still asking? Can some patients still benefit from a mastectomy, more extensive surgery? That's the inflammatory breast cancer patients. They still need a modified radical mastectomy. Maybe someday lumpectomy. We're not there yet. Because their tumor plugs the lymphatic, so your sentinel lymph nodes are not accurate. Trials, we can safely omit axillary surgery to shrink tumor before operating. Equity and access to these advances are not yet universal. And this is the reason I'm here educating you all and also on my podcast is this type of knowledge and information is not available outside the United States, maybe not even in the United States, in some parts of the United States. And so it's important for us to not only learn, but also educate others. That's how we pass, that's how we become immortal, is by passing our knowledge to others. And the evolution did not happen in isolation. So many women underwent, took part in this trial, sacrificed themselves. So people like me who came after them is able to live this happy life. And I'm living my best life because of all these sacrifices that were made by these women before me. Because they all happened because patients questioned, advocates demanded funding, women entered medicine, and survivors shared stories. We still need to keep asking quality of life. I bring this up at every tumor board. It seems like everyone talks about survival. We need to be talking about quality of life. A person should not be on tamoxifen or aromatase inhibitor at the cost of them having fractures, at the cost of them affecting their mental health. We really need to give patients a choice in that aspect. When it's so detrimental that they're not living a good quality of life, then what is the point of them living at all? And as a cancer survivor, I can say that. Body image is a big part of the conversation. We have scars. I have extreme keloids on my chest. I have scars. But I love myself way more now than, before my surgery. It's all because I had to change the dialogue in my head about what body image is all about. It comes from the inside, not outside. But a lot of us in America, 85% of us have issues with body image even before the cancer diagnosis. Mental health is a big thing. And I think as a surgeon, I have to ask these questions, not just removing the cancer. That's only one part of healing the patient is removing the tumor. But it's important for me to look at the whole patient, treating the whole patient, making the treatment to be personalized to that patient rather than just saying, oh, my job is done, I've removed your tumor. And as a women surgeon practicing today, I stand on the shoulders and I cannot, and this is why I want to talk about this to you guys today is I just want to take a moment and be just grateful for all these people who refuse to accept disfigurement as an only option. And as a survivor, I'm deeply grateful for the science that allows women to choose today. So, take home message radical means bigger operation does not mean better survival. Evidence overturned a century of surgical dogma. Evolution of breast cancer surgery is a story of science, humility, and listening to patients. And story of breast cancer surgery is not just about medicine. It's about having the courage to say we were wrong. And I think as a surgeon, I should be able to say, I'm sorry, I was wrong, but I want to learn. I want to get better. And we want to keep wanting to continue to get better because I don't think there comes a day when we are all perfect in any way. So when we follow science, we win. When we listen to patients, care improves. And that's all I have for you guys. And thank you so much for taking the time. I've really enjoyed doing this series with you. And Nicole had this recommendation of me recording the video, and I'm actually going to be out on my mission trip on March 7th. And then March 6th, I had to add some surgeries. So I wouldn't be with you guys in person, but I just wanted to record it so you can watch it in that hour that's blocked off for you guys. And please send me any questions, or we can talk about your questions the next time we meet. I love you all. Thank you so much for taking such great care of our patients. Bye bye.